Integrated care, which is really talking to each other, coming as a group, that's the best way to manage ADHD. So if we just take in isolation, somebody gets a diagnosis, we decide whether to put on Ritalin or not, that is, I think, the worst possible way of approaching this. And this is not only what the thought process is for NICE guidelines, SIGN guideline in this country. It is also the similar thought process in America, where ADHD is considered to be prevalent very high in the population, and management or treatment of ADHD is also considered very high. If you look at any comparative statistics, in UK, we say that the prevalence of ADHD is a lot less. There is a lot of debate about it, but what we can't ignore is that whether you've got the label or not, if the child has got behavioral challenges or other challenges which have got similar presentation to ADHD, we need to address those as well. And that is the crux of the matter. Whenever I see parents, they say, okay, doctor, fine, you can't make a diagnosis, but my child, my Tommy, still has got this problem. How do I address? Where do I go for to get the help? And I think the basis of the talk is that you as parent group or support group should be lobbying hard enough to actually go to people who have the purse to ensure that you are having an infrastructure outside the medical management or diagnosis to support the child, not only at home, in education, and also to support the family. I just wanted to start a little bit talking about DSM-5, which is what the American Association of Psychiatrists follow. What is new is that ADHD is now considered to be a neurodevelopmental disorder. It is just the way your brain is forming. It's no longer just a behavior. So it is an organic diagnosis. So it is something which has got a, you could say, I wouldn't like to use the word pathological, but I would again like to use the word neurodevelopmental issue, and has been included in the neurodevelopmental chapter. Previously, they did not acknowledge that as such. It was purely a behavioral thing. As we all know that it could be inattentive type, hyperactive impulsive type, and more often than not, they can overlap really. So, what we know about the new criteria in DSM-5, previously they would say to make a diagnosis of ADHD, the child should have symptoms at least from when he's under 7. Now that left out a huge proportion of children who were showing the symptoms later on. Exactly. They were the ones who were falling out, and we were underdiagnosing them. So the new criteria is that any child who is under 12, at any time under 12, who is showing signs and symptoms of or presentation of ADHD, and the persistence of those symptoms are up to 6 months, then they will definitely merit a diagnosis, provided you can match 6 symptoms. That also left out a lot of older children who are able to control their behavior. So for that, they said that we don't need all 6 symptoms, because you don't expect a lot of the young people to just jump around and do the things that a smaller child would do. So they said that if they have just 5 symptoms, it's enough for us to make a diagnosis of ADHD. It's important that we do so in a social, academic, occupational, any of the 2 settings. So occupational, I find it very interesting because a lot of young people were falling out of school. They were going to work. So even that can be taken as a criteria, and that really, it kind of embraces a whole new population or cohort of young people into it. Very important. Autism spectrum disorder, which was excluded from ADHD before, it is now included. So children can have overlap. And this is, I think, made a huge difference. Somebody who's autistic can have ADHD. And if the child needs to be managed and treated as such, we need to support that. So we also acknowledge that it goes well into adulthood. Okay, so I feel that to make a diagnosis of ADHD, what you as parents should be looking at is that whether you have had very searching questions and screening for your child when the child is facing any health professional for other comorbidities. A, to address them, B, to also be aware of it, and to understand that sometimes one comorbidity may mask the other. So unless and until we are actively searching for it, we will not be able to make a proper and sound diagnosis, and that would cause huge problem later on with the management of this child. So just to go through a little bit, I have put in the comorbidities: autistic spectrum, specific learning difficulties, attention deficit, Tourette, obsessive compulsive disorder. Then there is developmental coordination disorder, which is DCD. The child can be very clumsy. I have had a recent parent in my clinic who has got significant concern that her son has got auditory processing problems, and this is something that we are considering as a comorbidity. Depression, psychiatric help is tremendously needed, because recently in a workshop and it was a joint workshop with the CAMS team, it emerged how important it was to actively look for these subtle signs of psychiatric disorder, which may be a comorbidity. And anxiety, because anxiety may surface in different ways. It was very poignant. Once I had a young lady who was very smart, very articulate, and she was just starting on a GCSE. On the face of it, she looked very brave, very on top of things. But then when her mother left the clinic room just to give us some privacy, she told me, "Doctor, I'm desperate to start my studying and do my revision, and I can't do that. It is making me so anxious. My life is hanging on it. You've got to help me." So, it's this hidden anxiety. It may not all the time be apparent, and this was the time that her behavior was particularly bad, and she was trying to mask a lot of anxiety. She was just trying to hold everything inside. Right. Whichever criteria you use, these are some of the statistics that we have. If we have the International Classification of Disorder, then we have only 1 to 2% qualify as moderate ADHD, which is a significant low number.
What does that mean?
There are two ways of classifying ADHD. The DSM-4, or now we are using the DSM-5, it is the American classification. And International Classification of Disorder is what the World Health Organization is using. So there is a disparity, because if you use the International Classification Disorder, a lot less children will be fitting into a diagnosis. Okay, so NICE, 99.9% of doctors will follow the NICE recommendation. And if you don't follow, it's not set in stone. There are a lot of challenges, and there will be local variation. But if you're doing exactly the opposite thing, then you have to justify why you're doing that. You see, why I put this is that it is the gold standard, and it says drug treatment and behavioral or psychological interventions are extremely important, and that goes hand in gloves. So if you're not having one, it's unlikely that it is really, really going to make a lot of difference to you. And especially if you're talking about very young children, it's the behavior and the psychological intervention that is the gold standard. Because most doctors, most of us, do not like medicating children under 6, unless and until it's an extreme case and other options have been considered and failed. And it is the same in America as well, though they are very pro-medication, and they put children 4-year-old on medication. But it has been proved that if you are on a lower socioeconomic group area where the infrastructure is not good and you don't have behavioral intervention, those are the group of children who are getting higher medication, as opposed to the affluent group where the healthcare has invested sufficiently in providing alternative intervention. That's where the medication is, not because of lack of compliance, but because of other interventions possible, that the management is optimized. And this is what is the generic thought about stepped care model. So ideally, in an ideal world, tier 1 is GP, health visitor, school practice nurse. We have to empower them enough not only to understand ADHD, but just not, it could be ADHD, refer. It's not the thing. The thing is that what they're saying is that we have to empower them with better knowledge. I'll come back to this one, but if I don't manage, my thoughts on this would be, if we have an extremely good interactive, succinct web portal where you will get all the assessment tools, it is far better than any handouts and paper, because in real life none of us have the time to do that. But what we do all the time is that we are sitting in front of the screen, even with a patient. So what we can do is that we can immediately click on, and if we have to look at the quick snap score, and it takes literally 5 minutes to score up, and then you said this is, then when the doctor or the health visitor or the practice nurse says, that looks like, definitely it looks like ADHD. So the pickup rate is high. You're asking the right question. You're not dwelling on certain softer areas. So, that is more professional. Tier 2 is CAMS, or the pediatrician. So, in this case, it would be probably the SPA. But that's how we are working on. Developmental assessment is very, very important. So whether you do it with a pediatrician or whether there are trained people to do it, that's different. But my view is that without doing a proper developmental assessment and without actually screening for comorbidities at this stage, it could be a very poor care or management for this child. The Tier 3 is really, we are talking of a team. So pediatrician, psychiatrists, clinical psychologists, maybe speech and language therapists, occupational therapists, they are the core people who form the bulk of Tier 3 management. And if we don't have such facilities, that's something to be fighting for, because a lot of your children will need other care and will need other intervention. Tier 4, it's a nationwide debate because we don't have many Tier 4 we have to set up, and these are the institutions who sit above the Tier 3 CAMS, and they are the ones to support if it's a very complex diagnosis or there is a complication where you are adding 3 to 4 medication and there is a pharmacological implication. These are the institutions who should be taking care of such complex children after the screening has been done. It is not by direct referral. So next bit is, as I said, what is the success, key to the success of step care approach? Better training of professionals, your information, the way you set up information, it should be accurate, up to date, succinct, interactive. So anybody, whether you're a mother or a parent or a GP or a health visitor or a school teacher or a nurse, you should be able to download any set of single sheet of papers. You can do a rapid assessment, you can give away to the parents. Unless and until you're able to do that, you'll fight with the logistic of creating a folder every time, and the onerous task of really looking through the folder, it doesn't happen. So an interactive web portal, I would say that is something. Having regular ADHD days, training sessions, camps, pediatrician, anybody can be involved with these sessions. These are very important to do that. Also, in my mind as a clinician, I think there should be ways and means where better information based on clinical trials, which has been already screened by professionals, should be available to the parents, because you are exposed to unrestricted, unedited internet. You don't know what to take, what not to take, which to believe, what not to believe. So that creates huge amount of I would say distress to the parents, really. Distress to the parents. You're overloaded with information and you don't know which way to go for and how to go about it. So I really liked it. I went to this recent workshop. It was in St. Peter's Hospital in Chertsey, and ADHD Foundation, which is now in partnership with All the Hay. What they've done is that they have done a very good integrated care pathway model. According to the CEO, this is the first that has been done in the country and it's working very well. A second such a care pathway has been organized in Manchester by the same group. So ADHD Foundation takes referral from All the Hay, GP, pediatricians, any 14-year-old with self-referrals, parents, schools, and any other agency, social services, anywhere. Administrators or the managers, care managers, with better interview techniques, follow-ups, triple P, how to address from scripted. They had scripts for different behavioral issues and strategies, and they could actually prove that this made an impact in the management of children who had consistent symptoms of ADHD. And that is the reason why I wanted to show it, because it's not medicine, it's just the way it has been set up in a primary care. So they were also assessing inattention. These are the things that they were looking at: inattention, hyperactivity, impulsivity, oppositionality, and social skills. And it was 1 year that they had looked through the study, and they found significant, important improvement by the second half of the 6 months. Not the overall, but only in those group of children who had consistent ADHD symptoms. So what did the care managers do? They did not have any formal mental health training. So they took the Vanderbilt ADHD diagnostic rating skills from parents and teachers. They had the script, how to take the medical history, behavioral history, social history. They were the go-between, the primary care providers, and the decision. The decision was always made by healthcare professionals, pediatricians, psychiatrists, those kind. But they were very much the middle people in liaison, and these specialized healthcare managers actually had 5 encounters with the parents. And that made a lot of difference. They were particularly trained in how to deal with parents who were not engaging with behavioral health care. They received training for that. They were also trained how to pick up any mental health issues among the parents and signpost and facilitate that. They were also trained with strategies which were standard strategies, and they knew what to ask for, how to address, and what strategies to provide for. So it's very much scripted. It's a bit of an American thing, but it did make a difference because we are talking about primary health care. I just pulled out what was the essential things. There were no difference overall, but as I said, only in those group of children who had consistent ADHD symptoms, it seemed to make a lot of difference in their social skills, reduce their hyperactivity, and made a difference in the medical compliance and overall improvement in their symptoms of ADHD. An overview, but I would like to say that ADHD is now a neurodevelopmental diagnosis. It's no longer just a behavioral one.